Hepatitis B remains a public health problem in the United States, even though a safe and effective vaccine has been available since 1981. Hepatitis B vaccine is also one of the most common topics of questions we receive. So we are going to begin this module with a discussion of hepatitis B and address some of the vaccine issues that generate a lot of questions. Hepatitis as a distinct clinical entity has been recognized for 2,500 years. It took another 2,400 years to recognize that there was more than one type, and that one of them was transmitted by exposure to human blood or blood products. As a cause of liver disease and cancer, hepatitis B is a disease of enormous global importance. It is caused by hepatitis B virus, or HBV. HBV is a small DNA virus, very specific to humans. Although the virus is most closely related to viruses which cause hepatitis in woodchucks, ducks, and ground squirrels, humans are the only known host. The virus has never been grown in tissue culture, which is why the first vaccine was obtained from chronically infected humans. There are several HBV subtypes that do not affect virulence or infectivity, but can be useful in epidemiologic investigations. HBV may retain infectivity for more than 7 days at room temperature. Here's a schematic of HBV. The virus has several antigens, but for the purpose of this program, you only need to know about hepatitis B surface antigen. It is shown in this picture as HBsAg. This glycoprotein makes up the outer coat of the virus. Surface antigen itself is not infectious. Only the complete virus, known as the Dane particle, is infectious. But when HBV replicates, it produces surface antigen in huge excess, usually in the form of tubular and spherical structures like you see here. When we find surface antigen in a person's blood, we assume the complete virus is also there, and the person is actively infected and capable of transmitting the virus. So surface antigen acts as a marker for active infection. Another thing you need to know about the virus is that antibody to surface antigen indicates immunity to hepatitis B. Other hepatitis B antibodies can be measured, but only the presence of hepatitis B surface antibody indicates protection from infection, either from previous disease or vaccination. Now, we receive many questions about the interpretation of hepatitis B serologic test. A discussion of this topic is beyond the scope of this program, but we have included a table that will help you interpret these tests on the Update and Resources webpage. It is also in the course text. Hepatitis B is a disease of massive proportion. More than 2 billion persons worldwide have been infected with HBV, and more than 350 million persons have chronic lifelong infection. There are estimated to be more than 1 million chronically infected persons in the United States. Most chronically infected persons are not aware of their infection. The virus is an established cause of chronic hepatitis and cirrhosis and is estimated to be the cause of up to 80% of liver cancer. The World Health Organization estimated HBV was the direct or indirect cause of 600,000 deaths worldwide in 2002. The incubation period for acute hepatitis B averages 120 days with a range of 45 to 160 days. There may be a nonspecific prodrome of fever, malaise, and headache. The clinical illness is not specific for hepatitis B and usually includes anorexia, fatigue, abdominal pain, and jaundice. Infants, children younger than 10 years of age, and immunosuppressed adults with newly acquired HBV infection are usually asymptomatic. Age is the most important factor in whether an infected person has symptoms. Infection in infants is almost always asymptomatic. 5 to 50% of older children and 30 to 50% of adults will develop acute hepatitis following infection with HBV. The most important complication of acute hepatitis B virus infection is fulminant hepatitis, a severe form of acute hepatitis that may lead to acute liver failure. Fulminant hepatitis is estimated to occur in up to 1% of adults with acute hepatitis B virus infection. 10 to 15% of symptomatic infections require hospitalization. The major impact of hepatitis B is not the acute infection. It is the result of chronic infection with the virus. The most common long-term sequelae are cirrhosis and hepatocellular carcinoma. Death can result from either acute fulminant hepatitis or from the chronic disease. This is a Laotian woman with end-stage hepatocellular carcinoma from chronic HBV infection. She was probably infected with the virus by her mother when she was born. The enlarged abdomen is a result of a big liver and ascites, or fluid accumulation in the abdominal cavity. In the pre-vaccination era, an estimated 200 to 400 deaths occurred annually from acute fulminant hepatitis. But most of the mortality results from long-term persistent infection with the virus. Every year in the United States, an estimated 3,000 to 5,000 persons die from HBV-induced liver cancer and cirrhosis. Short of a major breakthrough in the treatment of chronic HBV infection, the number of annual deaths will not change very much anytime soon. That is because it usually takes 20 years or more of chronic infection to result in end-stage liver disease. So even if transmission of hepatitis B virus were completely stopped today, deaths from chronic infection would continue to occur for many years to come. Andrew?
Most persons who die from hepatitis B are chronically infected and have virus in their blood and body fluids continuously. Most persons who become chronically infected will remain infected the rest of their lives. The overall risk of becoming chronically infected is 5 to 10% and may result from either symptomatic or asymptomatic illness. In 2009, there were estimated to be 700,000 to 1.4 million persons chronically infected with HBV in the U.S. Several thousand newly infected persons become chronically infected every year. Although the immunologic mechanism of chronic infection is not well understood, risk factors for becoming chronically infected have been identified. The most important risk factor is the age of the person when the infection occurs. The earlier in life infection occurs, the higher the risk of becoming chronically infected. This graph shows the percent of infected persons who become chronically infected on the vertical axis by the age of infection along the horizontal axis. Up to 90% of infants infected at birth will become chronically infected. 50% of infections at 1 year of age will become chronic. By about 5 years of age, the risk of becoming chronically infected approaches the adult risk of about 5%. Infection early in life is very dangerous because it frequently leads to chronic infection. Chronic liver disease develops in 2/3 of persons with chronic HBV infection, and 15 to 25% will die prematurely from cirrhosis or liver cancer. Chronically infected persons also remain a source for transmission of virus for others. This is why the reduction of perinatal transmission has been one of the priorities of the U.S. hepatitis B control program. Our knowledge of the epidemiology of HBV has driven the vaccination recommendations since the vaccine was first licensed in 1981. Hepatitis B is a human disease, and the reservoir is humans with acute or chronic infection. It is bloodborne, that is, transmission results from contact with infected blood or body fluids derived from blood. In practice, the only body fluids likely to transmit HBV are blood, vaginal secretions, semen, and maybe saliva on very rare occasions. A human bite has been implicated in transmission. Persons with asymptomatic infections transmit the virus just the same as symptomatic persons. The virus is communicable 1 to 2 months before and after onset. This graph shows the number of reported cases of hepatitis B by year since 1978. The first hepatitis B vaccine was licensed in 1981. You might expect a decline in incidence after the vaccine was licensed, but the number of reported cases continued to rise. It peaked in 1985, then slowly declined. It is believed that the decline was not due to vaccine, but to HIV/AIDS education that led to behavioral changes among men who have sex with men and later among IV drug users. The rate of hepatitis B has declined 80% since 1990, due in large part to the implementation of universal childhood immunization. Since 2000, an average of about 7,600 cases of hepatitis B infection have been reported each year. But these reported cases only represent a fraction of the actual incidence. It is estimated that in the pre-vaccine era, 300,000 persons were infected annually with hepatitis B virus, including about 24,000 infants and children. Because of vaccination and risk reduction behaviors in high-risk groups, the number of new infections in the United States declined to an estimated 38,000 in 2009. In 2009, the highest rates of acute hepatitis B virus infection were among persons 30 through 39 years of age. Most of these infections were associated with high-risk sexual activity or injection drug use. Other exposures associated with infection include household and occupational exposures. In 1990, healthcare personnel accounted for 2% of HBV infections, 2,000 or 3,000 new infections each year. Since that time, the rate of infection among healthcare personnel has declined by 95% and is now lower than the rate for the general population. Hepatitis B vaccine has made occupational HBV infection a thing of the past. So the message from all this is that hepatitis B vaccine has led to a big decline in groups with high vaccination levels, children and healthcare personnel. But thousands of cases are still occurring, mainly among young adults. Reducing the disease burden in this group requires creative vaccination programs to reach high-risk adults, particularly in clinics that treat sexually transmitted diseases and injection drug use. Ray?
The first hepatitis B vaccine was licensed in the United States in 1981. The hepatitis B surface antigen for the vaccine was purified from the blood of chronically infected humans. In 1986, the first genetically engineered or recombinant hepatitis B vaccine was licensed. Plasma-derived vaccine was taken off the market in 1992. There are now 3 combination vaccines that contain hepatitis B that we will discuss a little later. All hepatitis B vaccines are composed of recombinant hepatitis B surface antigen. The antigen is produced in genetically engineered yeast cells. The yeast cells contain the part of the hepatitis B gene that codes for surface antigen. The vaccine does not contain any other part of the hepatitis B virus. The routine hepatitis B vaccine schedule is 3 doses. Vaccine efficacy after a full series is estimated at 95%, with a range of 80 to 100%. The duration of immunity is long, 22 years or longer. Routine booster doses are not recommended. Hepatitis B vaccine can and should be administered simultaneously with all other vaccines in both children and adults. It should be administered intramuscularly, either in the anterolateral thigh of an infant or the deltoid of an older child or adult. The hepatitis B vaccines available in the U.S. are produced by 2 different manufacturers, Merck and GlaxoSmithKline. Both companies produce both pediatric and adult formulations. Recombavax HB from Merck is available in 3 formulations: a pediatric formulation that contains 5 micrograms per half milliliter dose, an adult formulation with 10 micrograms per milliliter, and a dialysis formulation with 40 micrograms per milliliter. Engerix B from GlaxoSmithKline is available in 2 formulations: a pediatric formulation with 10 micrograms per half milliliter dose, and an adult formulation that contains 20 micrograms per milliliter. Both formulations are available without thimerosal as a preservative. This graphic shows the recommended dose of hepatitis B vaccine by age group and vaccine brand. All infants and children younger than 11 years of age, shown in the first row, receive a half milliliter dose of either Recombavax or Engerix. Although the amount of antigen in the half milliliter doses differs by manufacturer, the vaccines are considered equivalent and are completely interchangeable. Adolescents 11 through 19 years of age, in the second row, should also receive a half milliliter dose of either Recombavax or the pediatric formulation of Engerix. Adults 20 years and older should receive 1 milliliter of either Recombavax or the adult formulation of Engerix. As with the pediatric formulations, the adult formulation of Engerix has twice as much antigen per dose as Recombavax, but the vaccines are considered to be equivalent and are interchangeable. An adult who received 1 or 2 doses of adult Recombavax can complete the series with a dose of Engerix or vice versa. Do not be misled by the higher antigen content of Engerix. The fact that it has twice the antigen per dose does not mean that it is a better vaccine or that you can give a half dose if you should substitute Engerix for Recombavax. Children and adolescents 19 years and younger should receive a half milliliter dose, and adults 20 years and older should always receive a 1 milliliter dose regardless of which vaccine you are using. We get a lot of questions about waning immunity to hepatitis B vaccine and the need for booster doses. It is true that antibody levels may decline after vaccination. In fact, up to 50% of recipients may lose detectable antibody by 15 years after vaccination. But the level of antibody is only part of the issue. Persons who respond to the vaccine develop immunologic memory following vaccination. This means that B lymphocytes have been produced that are primed to produce more hepatitis B surface antibody the next time hepatitis B surface antigen is encountered. We know that this immunologic memory lasts for many years after successful vaccination. Antibody may drop to a low level, but an anamnestic or memory response occurs upon exposure to HBV, and antibody levels increase very quickly. Since the incubation period of HBV is so long, the immune system can mount a protective response before the virus can do any damage. Asymptomatic HBV infection has been occasionally documented in persons who responded to the vaccine, but chronic infection has rarely been documented among vaccine responders. Since chronic infection leads to severe sequelae and is responsible for most of the mortality, it is what we most want to prevent. Booster doses of hepatitis B vaccine are not routinely recommended for any group because there's no evidence that they are necessary for continued protection. Routine periodic serologic screening to assess the immune status of vaccinated persons is also not recommended, except for persons on dialysis and possibly for other immunocompromised persons. The duration of hepatitis B immunity following vaccination will continue to be studied for years to come, particularly among those vaccinated as infants. If breakthrough infections, particularly chronic infections, begin to appear 10, 20, or 30 years from now, booster doses may be needed, but not now. Donna?
The hepatitis B vaccination strategy has evolved since the vaccine was licensed in 1981. When new recommendations were made, they did not replace the prior recommendations. The recommendations were cumulative, so now hepatitis B vaccine is recommended for persons of many ages. Hepatitis B vaccine should be administered to all infants without contraindications beginning at birth. All adolescents through 18 years of age should receive hepatitis B vaccine if they have not already received it. The routine medical visit at 11 or 12 years is a good opportunity to be sure adolescents have been vaccinated. The vaccine should also be offered to adults at increased risk of HBV infection. An ACIP statement that specifically addresses hepatitis B vaccination of adults was published in December 2006. In it, ACIP recommends universal hepatitis B vaccination for all unvaccinated adults in settings in which a high proportion of adults are at increased risk of HBV infection. This would include settings such as sexually transmitted disease clinics, HIV testing and treatment facilities, drug abuse treatment and prevention settings, and correctional facilities. In other primary care and specialty medical settings in which adults at risk for HBV infection receive care, all patients should be provided information about the disease and benefits of vaccination. The vaccine should be available in these settings. We will include a link to this important document on the Program Resources webpage. Adults with diabetes mellitus, either type 1 or type 2, are at increased risk of HBV infection. This increased risk probably results from breaches in infection control during assisted blood glucose monitoring, such as reuse of single-patient finger stick devices. The Advisory Committee on Immunization Practices, or ACIP, had extensive discussions of this issue and in October 2011 made recommendations to help reduce the risk. ACIP recommends that all previously unvaccinated adults 19 through 59 years of age with diabetes mellitus, both type 1 and type 2, be vaccinated against hepatitis B as soon as possible after a diagnosis of diabetes is made. ACIP also recommended that unvaccinated adults 60 years of age or older with diabetes may be vaccinated at the discretion of the treating clinician after assessing their risk and the likelihood of an adequate immune response to vaccination. The recommendations for hepatitis B vaccination of adults with diabetes were published in Morbidity and Mortality Weekly Report in December 2011. We will include a link to the publication on the Program Resources webpage. The vaccination schedules are very similar for all age groups. The childhood hepatitis B vaccination schedule recommended by ACIP and the American Academies of Pediatrics and Family Physicians begins at birth. The second dose is given at 1 to 2 months of age, and the third dose at 6 to 18 months of age. Note the minimum intervals: 4 weeks between doses 1 and 2, and 8 weeks between doses 2 and 3. Do not give the vaccine at intervals shorter than these minimums. The third dose has 3 interval and age rules that you should follow. The third dose should be given a minimum of 8 weeks after the second dose and at least 16 weeks after the first dose. These 2 rules apply to anyone of any age receiving the vaccine. For infants, there is one more rule. The infant should be at least 24 weeks of age before receiving the third dose. The reason for these 3 rules is the desire to maximize the response to the vaccine. There are limited data on schedules other than these. If a dose of hepatitis B vaccine is given at an interval or age less than these minimums, the dose should not be counted. The 4-day grace period can be applied to these intervals if your state accepts it. Now, what about doses that are separated by longer than the recommended interval? As with all vaccines routinely used in the U.S., it is not necessary to restart the series or add additional doses if the interval between doses is prolonged. Just continue the series where it was interrupted. Preterm infants with a very low birth weight present a challenge. Infants who weigh less than 2,000 grams have a decreased response to hepatitis B vaccine. As a result, the first dose of vaccine should be delayed until the child is 1 month old if the mother is documented to be hepatitis B surface antigen negative. At 1 month of age, these infants respond as well as infants of normal birth weight. But this applies only to routine hepatitis B vaccination. Post-exposure management must be started immediately if the mother is hepatitis B surface antigen positive, or if the mother's surface antigen status is not known, regardless of the child's weight. Post-exposure management includes both vaccine and hepatitis B immune globulin, or HBIG. There's one other unique aspect of vaccination of preterm infants who weigh less than 2,000 grams. If the infant's mother is surface antigen positive or her status is not known, you should give a dose of hepatitis B vaccine at birth along with HBIG. But this first dose should not be counted. The infant should receive 3 additional doses beginning when the infant reaches 1 month of age. Andrew?
There are now 3 combination vaccines that contain hepatitis B: Comvax, Pediarix, and Twinrix. Comvax and Pediarix are approved only for children. Twinrix is approved only for adults 18 years of age and older. Comvax is a combination hepatitis B Hib vaccine produced by Merck and was licensed in 1996. Comvax contains a standard 5 microgram dose of Merck's pediatric hepatitis B vaccine and a standard dose of Merck's Hib vaccine, Pedvax Hib. Comvax does not contain thimerosal as a preservative. As with other combinations, the vaccine can be used when either component is indicated and neither component is contraindicated. Hib vaccine should not be given to infants younger than 6 weeks of age. So Comvax cannot be administered to infants younger than 6 weeks of age. Although not approved by FDA for this use, Comvax may be used if the infant's mother is known to be surface antigen positive or not known. ACIP approved this off-label use of Comvax in 1997. These infants must receive a birth dose of monovalent hepatitis B vaccine, and the hepatitis B series can be completed with Comvax beginning at 6 to 8 weeks of age. In 2002, the Food and Drug Administration licensed a combination vaccine, Pediarix, which is manufactured by GlaxoSmithKline. This vaccine contains DTaP, inactivated polio, and hepatitis B vaccines. The DTaP component is Infinrix, and the hepatitis B component is Engerix B, which were previously licensed in the U.S. Pediarix is approved for the first 3 doses of the DTaP and IPV series, which are usually given at about 2, 4, and 6 months of age. It is not approved for the booster doses of DTaP or IPV. However, Pediarix is approved for use through 6 years of age. The minimum age for the first dose of Pediarix is 6 weeks, so it cannot be used for the birth dose of the hepatitis B series. Pediarix may be used in infants born to women who are hepatitis B surface antigen positive or whose hepatitis B status is not known. Like Comvax, Pediarix is not approved by FDA for this use. But in 2003, ACIP approved the off-label use of Pediarix to complete the hepatitis B series for these infants. But remember that the minimum age for Pediarix is 6 weeks, so it must not be used for the birth or 1-month dose of the hepatitis B series. I would like to remind you of the combination vaccine interval rule. It is that the minimum intervals between doses of a combination vaccine are dictated by the single antigen with the longest minimum intervals. So for Pediarix, the minimum intervals are determined by the hepatitis B component. As for hepatitis B vaccine, the minimum interval between the first 2 doses of Pediarix is 4 weeks. The 3rd dose must be administered at least 8 weeks after the 2nd dose and should follow the first dose by at least 16 weeks. To be counted as a valid final dose of hepatitis B vaccine, the 3rd dose should not be administered before 24 weeks of age. One more point about combination vaccines that contain hepatitis B vaccine. All infants should receive a dose of hepatitis B vaccine shortly after birth. The birth dose should always be single antigen hepatitis B vaccine. Either Comvax or Pediarix can be used to complete the hepatitis B schedule for children that receive a birth dose. This means the child will receive 4 doses of hepatitis B vaccine. This is not a problem. It is not necessary to switch back and forth between a combination and single antigen hepatitis B vaccine just to avoid giving 4 doses. Just go ahead and use the combination vaccine as usual, even though this will result in 1 extra dose of hepatitis B vaccine for the child. The 3rd combination vaccine that contains hepatitis B vaccine is Twinrix. Twinrix is produced by GlaxoSmithKline and was licensed by FDA in 2001. It contains a standard adult dose of GSK's hepatitis B vaccine, Engerix B, and a pediatric dose of their hepatitis A vaccine, Havrix. The standard schedule is a 3-dose series at 0, 1, and 6 to 12 months. Twinrix is approved only for adults 18 years of age and older. A pediatric version of Twinrix is licensed in some other countries, but is not available in the United States. Since Twinrix contains a standard adult dose of hepatitis B vaccine, it can be used interchangeably in a schedule with monovalent hepatitis B vaccine. We will discuss an alternate Twinrix schedule and schedules that include both Twinrix and monovalent hepatitis A in the hepatitis A segment of the program. All children and adolescents through 18 years of age should receive hepatitis B vaccine. Adults at increased risk of HBV infection should also be vaccinated. The routine adolescent and adult schedule is 3 doses. For the usual schedule, the first 2 doses should be separated by at least 1 month, and the third dose is usually given 5 months after the second. If an accelerated schedule is required, the minimum interval between the second and third doses is 8 weeks. The first dose should always be separated from the third dose by at least 16 weeks. Adolescents should receive 1/2 milliliter of pediatric formulation. Adults 20 years and older should receive 1 milliliter of adult formulation. In 1999, Merck received FDA approval for an alternative hepatitis B vaccination schedule for adolescents. This alternative schedule is for 2 adult doses, 10 micrograms, of Recombavax HB separated by 4 to 6 months. Seroconversion rates, post-vaccination antibody titers, and adverse reactions were similar using this schedule and the standard schedule of 3 5-microgram doses of Recombavax HB. This alternative schedule may only be used for adolescents 11 through 15 years of age, and the schedule only applies to the Merck hepatitis B vaccine. I want to repeat this. If you decide to use this 2-dose schedule for adolescents in your practice, it must not be started before age 11 and should be completed by the 16th birthday. If the child has already received 1 or more 5-microgram pediatric doses, he or she should complete the regular 3-dose series and not be switched to the 2-dose series. Also, Engerix B is not approved for this schedule. In this situation, the 2 vaccines are not interchangeable. One final note on the 2-dose adolescent schedule. If you decide to use it, please document clearly in the vaccination record. If you just record hepatitis B vaccine without noting the dose, someone reviewing the record will assume appropriately that it was a standard pediatric dose. So please document the doses you administer clearly and don't make anyone guess. Ray?
We receive many questions about serologic testing after vaccination. In most circumstances, it is not necessary. Post-vaccination serologic testing is not recommended after routine vaccination of most infants, children, adolescents, or adults. But there are situations where it is recommended. These include infants born to hepatitis B surface antigen positive women, either acutely or chronically infected, hemodialysis patients, immunodeficient persons, sex partners of persons with chronic HBV infection, and certain healthcare personnel. Since 1997, ACIP has recommended that healthcare personnel who have contact with patients or blood and are at ongoing risk for injury with sharp instruments or needles should be tested for antibody after vaccination. Routine testing is not recommended for persons at low risk of exposure, such as public safety workers and healthcare personnel without direct patient contact. Testing for antibody to hepatitis B surface antigen should be done 1 to 2 months after the 3rd dose of vaccine. Now, what about the thousands of healthcare personnel who were vaccinated before the 1997 recommendations were published? ACIP does not recommend catch-up serologic testing programs. These persons can be tested as necessary if they are exposed. All healthcare personnel who may be exposed to blood or Sharp's injury should have written documentation of having received a 3-dose series of hepatitis B vaccine. Healthcare personnel who cannot provide this documentation should be vaccinated, even if they test positive for hepatitis B surface antibody. Post-vaccination serologic testing will occasionally reveal someone who failed to respond to a series of 3 doses that were properly administered. Persons who do not respond to the first series of 3 doses should complete a second series of 3 doses or be evaluated to determine if they are already chronically infected. Persons who do not respond to an initial 3-dose series have a 30 to 50% chance of responding to a second 3-dose series. The second series should be given on the usual schedule of 0, 1, and 6 months, but an accelerated schedule of 0, 1, and 4 months can also be used. Revaccinated persons should be retested for an antibody response 1 to 2 months after completing the second series. If you test enough people, you will eventually encounter someone who fails to respond to 6 doses of hepatitis B vaccine. You need to evaluate the person for chronic HBV infection if this has not already been done. ACIP does not recommend more than 6 total doses of hepatitis B vaccine for otherwise healthy persons. Those who fail to respond to 6 doses and are not surface antigen positive should be assumed to be susceptible and be given post-exposure prophylaxis with hepatitis B immune globulin if a high-risk exposure occurs. The most recent recommendations for post-exposure prophylaxis after occupational exposure to HBV were published with the ACIP healthcare personnel vaccination recommendations in 2011. A table in this document can help you determine when HBIG is needed. There is a link to the document on the Program Resources webpage. Hepatitis B vaccine has few true contraindications and precautions. The only contraindication is a severe allergic reaction to a vaccine component or following a prior dose. Moderate or severe acute illness is a precaution. Vaccination should be deferred until the acute illness improves. Hepatitis B vaccine is inactivated, and adverse reactions following it are similar to those following other inactivated vaccines. Pain at the injection site is reported in 13 to 29% of recipients. Mild systemic complaints, such as fatigue or headache, are reported in 11 to 17% of adults. A temperature 100 degrees Fahrenheit or higher occurs in only about 1% of recipients. Transmission of hepatitis B virus in the perinatal period is extremely dangerous because it leads to chronic infection for up to 90% of infected infants. All pregnant women should be tested at least once for hepatitis B surface antigen status during each pregnancy. Women who are not screened during early pregnancy or who engage in behaviors that put them at high risk for infection, such as injection drug use, should be tested at the time of admission to the hospital for delivery. Infants born to women who are hepatitis B surface antigen positive must receive post-exposure prophylaxis immediately after birth. The basic recommendations for perinatal management are summarized on this next graphic. For a newborn whose mother is acutely or chronically infected with HBV, begin treatment within 12 hours of birth. In the first 12 hours, give hepatitis B vaccine and HBIG at different sites, for example, each thigh. For infants weighing at least 2,000 grams at birth, give or ensure that someone gives the second dose at 1 to 2 months of age and complete the series by 6 months of age. An infant who weighs less than 2,000 grams at birth and whose mother is hepatitis B surface antigen positive should get a total of 4 doses of vaccine to complete the series. Test the child for anti-HBs and hepatitis B surface antigen after completion of at least 3 doses of hepatitis B vaccine at 9 to 18 months of age, that is, about 3 months after the final dose of the vaccination series. Prevention of perinatal and early childhood infection by providing hepatitis B vaccine to newborns is a critical element of our hepatitis B prevention strategy. More details about implementation of the birth dose and prevention of perinatal HBV transmission can be found in Part 1 of the Hepatitis B ACIP Statement, published in December 2005. The document also includes information on management of women found to be surface antigen positive, hepatitis B post-exposure prophylaxis, and much more. We will have a link to these recommendations on our Program Resources webpage.
Outbreaks of jaundice, which were probably hepatitis A, were reported in the 17th and 18th centuries, often associated with military campaigns. Hepatitis A was originally called infectious hepatitis and was differentiated epidemiologically from long incubation period hepatitis B in the 1940s. The development of serologic tests in the 1970s helped differentiate hepatitis A from other types of non-B hepatitis. Hepatitis A virus was first isolated in 1979, and a vaccine was first licensed in 1995. Hepatitis A virus, or HAV, is a picornavirus with an RNA genome. Humans are the only natural host, although some non-human primates can be infected in laboratory conditions. Depending on conditions, HAV can survive in the environment for months. The virus is relatively stable at low pH levels and moderate temperatures, but can be inactivated by temperature above 185 degrees Fahrenheit, formalin, and chlorine. HAV infection is acquired by mouth, and the virus replicates in the liver. After 10 to 12 days, virus is present in blood and in the feces. A large amount of virus is shed in the stool of an infected person. The incubation period of hepatitis A is 15 to 50 days, with an average of about 28 days. Symptomatic illness is not specific for hepatitis A and is indistinguishable from other types of acute viral hepatitis. Hepatitis A typically has an abrupt onset of fever, malaise, anorexia, nausea, abdominal discomfort, dark urine, and jaundice. Clinical illness usually lasts less than 2 months, but 10 to 15% of infected persons have prolonged or relapsing signs and symptoms for up to 6 months. The likelihood of symptomatic illness from HAV infection is directly related to age. Children younger than 6 years of age are generally asymptomatic. Older children and adults usually have symptoms, with jaundice occurring in more than 70% of patients. Unlike hepatitis B virus, infection with hepatitis A virus does not lead to chronic infection, so complications of hepatitis A are related to the acute disease. 10 to 20% of persons with symptomatic hepatitis A require hospitalization. The overall case fatality rate is about 0.3%, or about 1 in 330 reported cases. But the fatality rate may be as high as 2% among persons 40 years of age and older. Death is caused by fulminant hepatitis and liver failure. Adults with hepatitis A lose an average of 27 workdays per illness. Health departments incur the cost of post-exposure prophylaxis for 11 contacts per case. In the pre-vaccine era, the estimated annual cost of hepatitis A in the United States was more than $200 million. Andrew?
The epidemiology of hepatitis A is changing in the United States. In some populations, it has changed a lot, and we think these changes are because of the vaccine. Hepatitis A is endemic throughout the world. Humans with acute hepatitis A virus infection are the only reservoir. Chronic infection does not occur as it does for hepatitis B virus infection. Hepatitis A is transmitted by the fecal-oral route, either by direct person-to-person contact or ingestion of contaminated food or water. The virus is shed in the stool and is communicable 2 weeks before the onset of illness until a week after the onset of jaundice. The risk for transmission of hepatitis A virus depends on host and environmental factors and varies in different settings. For example, without post-exposure prophylaxis, secondary attack rates of 15% to 30% have been reported in households, with higher rates of transmission occurring from infected young children than from infected adolescents and adults. In contrast, attack rates are low among patrons of food service establishments who have been exposed to food handlers with hepatitis A virus infection. Most infected food handlers do not transmit hepatitis A virus to exposed consumers or restaurant patrons. This table shows the most common sources of infection of reported hepatitis A cases in the U.S. in 2007. The most frequently reported source was international travel, reported in 18% of cases. 9% of cases reported attending or working in a child care setting or contact with a child care employee. Sexual or household contact with a person with hepatitis A accounted for 8% of cases. 7% of cases were suspected of being outbreak-related. Men who have sex with men, shown here as MSM, accounted for about 6%. 1% of cases had a history of injection drug use. Some reported cases of hepatitis A had more than one possible source. 2/3 of reported cases had no known source of infection. Groups at increased risk of hepatitis A include international travelers, men who have sex with men, and users of illegal drugs. Persons at occupational risk of hepatitis A are limited to persons working with non-human primates or those working with hepatitis A virus in a research laboratory setting. The highest rates of reported hepatitis A are in older children and young adults. In 2007, the highest rates were among adults 25 through 39 years of age. The incidence of reported hepatitis A in children younger than 5 years is substantially less than older children. But cases in this age group are underreported because most infections in young children are not symptomatic. This graph shows reported cases of hepatitis A by year since 1966, when it became nationally reportable as a distinct entity. Reported cases peaked in 1971 with more than 59,000 cases. Notice the cyclic increase in cases about every 10 years. The last peak occurred in 1995, but the incidence of hepatitis A is high even between the peaks. Reported cases of hepatitis A fell dramatically after 1999. Only 1,670 cases were reported in 2010, the lowest annual total since reporting of hepatitis A began in 1966. This spectacular decline in hepatitis A is almost certainly a result of vaccination. In the pre-vaccine era, much of the disease reported in the U.S. was occurring in the western regions of the country. In 1999, ACIP recommended that children living in the 11 states which historically had the highest rates of hepatitis A be routinely vaccinated against the disease. Reported cases of hepatitis A declined rapidly in the years after this recommendation was made. The decline was greatest in the states where routine vaccination of children was recommended in 1999. ACIP expanded this recommendation in 2005 to include routine hepatitis A vaccination to all areas of the country. The result of these recommendations is the record low hepatitis A reporting we have now. Ray?
Hepatitis A vaccine was first licensed in the United States in 1995. 2 hepatitis A vaccines are now available. Both vaccines are inactivated whole virus vaccines. Havrix is GlaxoSmithKline's vaccine. Vacta is produced by Merck. The vaccines are considered equivalent and interchangeable. Both are given as a single dose, with a booster dose 6 to 18 months after the first dose. Both vaccines are available in pediatric and adult formulations. The pediatric formulations of both vaccines are for persons 12 months through 18 years. The adult formulations are for persons 19 years and older. The pediatric and adult formulations of both vaccines are supplied as liquid vaccine in prefilled syringes and single-dose vials. Both manufacturers' prefilled syringe and the Vacta single-dose vial contain dry natural latex rubber. Neither vaccine contains thimerosal as a preservative. Hepatitis A vaccines are highly immunogenic, and large trials have produced estimates of 94 to 100% protection against clinical hepatitis. In clinical trials, 95% of adults are seropositive for hepatitis A antibody within a month following 1 dose, and 100% are seropositive after 2 doses. The vaccines are just as impressive in children 12 months and older, and in adolescents with more than 97% seropositive after 1 dose, and 100% seropositive after 2 doses. For both vaccines, the schedule is 1 dose with a second or booster dose at least 6 months after the first dose. The booster dose should be based on the person's age at the time of the booster, not the age when the first dose was given. For example, if a child received the first dose of the pediatric formulation of Vacta at 18 years of age and returns for the booster dose at age 19 years, the booster dose should be the adult formulation, not the pediatric formulation. The minimum interval between the first and booster doses of hepatitis A vaccine is 6 calendar months. If the interval between the first and booster doses of hepatitis A vaccine is longer than the recommended interval of 6 to 18 months, it is not necessary to repeat the first dose. ACIP recommends that all children should receive hepatitis A vaccine at 12 through 23 months of age. Vaccination should be integrated into the routine childhood vaccination schedule. Children who are not vaccinated by 2 years of age can be vaccinated at subsequent visits. A 2-dose vaccine series is also recommended for unvaccinated persons 24 months of age and older for whom immunity against hepatitis A virus infection is desired. Some areas in the U.S. already have an existing hepatitis A vaccination program for children 2 through 18 years of age. These programs should be maintained. Efforts focusing on routine vaccination of children 12 months of age should enhance, not replace, ongoing vaccination programs for older children. In areas without an existing hepatitis A vaccination program, catch-up vaccination of unvaccinated children 2 through 18 years of age can be considered. ACIP does not recommend a routine catch-up vaccination program. However, such programs might be warranted in the context of rising incidence or ongoing outbreaks among children or adolescents. Andrew?
ACIP continues to recommend hepatitis A vaccination for groups at increased risk of HIV infection. In 2009, ACIP added a new group to those recommended for routine hepatitis A vaccination. ACIP now recommends vaccination for all previously unvaccinated persons who anticipate close personal contact, such as household contact or regular babysitting, with an international adoptee from a country of high or intermediate endemicity during the first 60 days following arrival of the adoptee in the United States. The first dose of the 2-dose hepatitis A vaccine series should be administered as soon as adoption is planned, ideally 2 or more weeks before the arrival of the adoptee. The traditional high-risk groups targeted for hepatitis A vaccination include international travelers, men who have sex with men, drug users, both injecting and non-injection, and persons with occupational risk. This group is limited to certain laboratory workers and animal handlers. It does not include healthcare personnel, emergency or first response personnel, or persons with occupational exposure to sewage. Vaccination is recommended for persons with chronic liver disease. Persons with chronic liver disease are not necessarily at increased risk of HIV infection, but are at increased risk of complications of hepatitis A. Hepatitis A vaccination is recommended for persons 12 months of age and older traveling to countries with high or intermediate risk of hepatitis A virus infection. These areas include basically the entire world except Canada, Western Europe, Scandinavia, Japan, New Zealand, and Australia. Historically, international travelers often received immune globulin for passive protection against hepatitis A virus infection. Before October 2007, ACIP recommended that persons traveling to a high-risk area less than 4 weeks after the first dose of vaccine could also receive immune globulin for optimal protection. In October 2007, ACIP published revised recommendations for the use of hepatitis A vaccine and IG among international travelers. The first dose of hepatitis A vaccine should be administered as soon as travel is considered. For healthy persons 40 years of age or younger, 1 dose of single antigen vaccine administered at any time before departure can provide adequate protection. Adults older than 40 years, immunocompromised persons, and persons with chronic liver disease are at increased risk of severe hepatitis A. Prevention of hepatitis A virus infection in these groups is vital. Persons at risk of severe disease from hepatitis A virus planning to travel in 2 weeks or sooner should simultaneously receive the first dose of vaccine and immune globulin. Vaccine and IG should be administered with separate syringes at different anatomic sites. Hepatitis A vaccine is not approved for children younger than 12 months of age, so these children should continue to receive immune globulin prior to travel to a high-risk area. In the same October 2007 publication, ACIP also revised its recommendations for hepatitis A post-exposure prophylaxis. In the past, only immune globulin has been recommended for post-exposure prophylaxis. Based on data comparing IG and hepatitis A vaccine, ACIP recommended that vaccine can be used without IG for some persons. For healthy persons 12 months through 40 years of age, single antigen hepatitis A vaccine at the age-appropriate dose should be administered as soon as possible after exposure. Vaccine is preferred to IG because of vaccine advantages that include long-term protection and ease of administration. For persons older than 40 years, immune globulin is preferred because of the absence of information regarding vaccine performance and the more severe manifestations of hepatitis A in this age group. Vaccine can be used if IG cannot be obtained. Immune globulin should be used for children younger than 12 months of age, immunocompromised persons, persons with chronic liver disease, and persons for whom vaccine is contraindicated. More details on these recommendations are in the October 19, 2007 edition of Morbidity and Mortality Weekly Report. Ray?
In addition to single antigen formulations, hepatitis A vaccine is also available in a combination vaccine. Twinrix is produced by GlaxoSmithKline and was licensed by FDA in 2001. It contains a standard adult dose of GSK's hepatitis B vaccine, Engerix, and a pediatric dose of their hepatitis A vaccine, Havrix. The vaccine is administered in a 3-dose series at 0, 1, and 6 to 12 months. Twinrix is approved only for adults 18 years of age and older. No pediatric version of Twinrix is available in the United States. In 2007, the Food and Drug Administration approved an alternative schedule for Twinrix. We've received many questions about this schedule. Although the company refers to it as an accelerated schedule because of the timing of the first 3 doses, it actually requires a year to complete and requires 4 total doses. The alternative schedule is doses at 0, 7, and 21 to 30 days, and a booster dose at 12 months. Like the standard Twinrix schedule, this schedule is also approved only for persons 18 years and older. Based on immunogenicity data submitted to the Food and Drug Administration and in the medical literature, the first 3 doses of the alternative Twinrix schedule provide equivalent protection to the first dose in the standard single antigen adult hepatitis A vaccine series and the first 2 doses in the standard adult hepatitis B vaccine series. ACIP has not made a recommendation for the use of this schedule. It is our opinion that the standard schedules of either Twinrix or single antigen vaccines should be used whenever possible for 2 reasons. The first is cost. 3 doses of Twinrix on the standard schedule are less expensive than the 4 doses required for the alternative schedule. The second is because of the time required to complete the series, 6 months for the standard schedule and 12 months for the alternative schedule. The alternative schedule may be useful when travel or other potential exposure is imminent, that is, in less than a month. In this situation, the second dose of hepatitis B vaccine or Twinrix cannot be administered according to the standard schedule 1 to 2 months after the first dose. There is no apparent benefit of the alternative schedule for the hepatitis A vaccine component. Seroconversion is nearly 100% after either 3 doses of Twinrix or 1 dose of single antigen adult hepatitis A vaccine. There is also no apparent benefit of the alternative schedule for the hepatitis B component compared to administration of 2 doses of single antigen adult hepatitis B vaccine 1 to 2 months apart. In addition, both hepatitis A vaccine and the hepatitis B vaccine series are known to be effective when the series are begun at the time of exposure. We have no data on how to manage a person who starts on the alternative schedule and then has a lapse in the schedule. But it would seem reasonable that if exposure was still imminent, to just continue the series where it was interrupted. But if the lapse occurs after the first dose of the alternative schedule, and the second dose can be administered according to the standard schedule 1 to 2 months after the first dose, we suggest reverting to the standard schedule of either Twinrix or single antigen vaccine. We receive many questions about the use of Twinrix and single antigen hepatitis A vaccine in the same series. Schedules using both vaccines have not been studied, but here are some general principles that can be applied to this situation. Adult formulation single antigen hepatitis A vaccine may be used to complete a schedule begun with Twinrix and vice versa. However, interchanging the vaccines will still require a total of 3 doses. Schedules that include 2 doses of Twinrix can be completed with 1 dose of adult formulation hepatitis A vaccine. Schedules that include 1 dose of Twinrix must include 2 doses of adult formulation hepatitis A vaccine. The hepatitis A component of Twinrix is not counted since it is equivalent to half an adult dose. If you substitute hepatitis A vaccine for Twinrix, you should maintain the spacing recommended for Twinrix, 1 month between doses 1 and 2, and 5 months between doses 2 and 3. If protection from hepatitis A is needed in a month, then you should consider using single antigen hepatitis A vaccine rather than Twinrix. The seroconversion rate 1 month after a dose of single antigen vaccine is about 98%. Seroconversion a month after a dose of Twinrix is about 90%. Hepatitis A vaccine should not be administered to persons with a history of severe allergic reaction to a vaccine component or following a prior dose. Vaccination of persons with moderate or severe acute illness should be deferred until the illness improves. The safety of hepatitis A vaccination during pregnancy has not been determined. However, because it is an inactivated vaccine, the theoretical risk to the fetus is low. The risk associated with vaccination should be weighed against the risk for HAV infection. Because hepatitis A vaccine is inactivated, no special precautions are needed when vaccinating immunocompromised persons. For both hepatitis A vaccines, the most frequently reported adverse reaction following vaccination is a local reaction at the site of injection. Injection site pain, erythema, or swelling is reported in 20 to 50% of recipients. These symptoms are generally mild and self-limited. Mild systemic reactions such as malaise, fatigue, and low-grade fever are not common and are reported in fewer than 10% of recipients. No serious adverse reactions have been reported. Routine hepatitis A vaccination of children is preventing a substantial number of HAV infections. Vaccination of children also eliminates a major source of infection for other children and adults, the group that tends to get more severe disease. Eventually, this strategy will prevent infection in adults who were vaccinated as children because immunity appears to persist for many years.
We will now present a case study that addresses issues that we have discussed during this program. The case studies are available on the Program Resources webpage for this program. Min is a 5-week-old infant being seen in your office for the first time today. Min was born 5 weeks premature and weighed 1,800 grams at birth. She was hospitalized for 3 weeks after she was born. She has done well and gained weight in the 2 weeks since she was discharged from the hospital. Min's mother is known to be chronically infected with hepatitis B virus. Min received her first dose of hepatitis B vaccine 8 hours after she was born. She also received 0.5 milliliters of hepatitis B immune globulin. She has not received any subsequent doses of hepatitis B vaccine. She is scheduled to receive her second dose of hepatitis B vaccine in your office today. Here are questions about men. After today's visit, how many more doses will men need to complete her hepatitis B series? Your office stocks Pediarix, the DTaP-IPV hepatitis B combination vaccine. Can men receive Pediarix today? When should men return for her next dose of hepatitis B vaccine? Should men be tested for hepatitis B immunity? And if so, when should the testing be done? If you are viewing this program with a group, we suggest you pause the program now and discuss it among yourselves. We will return in a moment to discuss it with you. Hepatitis B virus is very efficiently transmitted between a woman who is chronically infected and her newborn infant. Transmission is believed to occur primarily at the time of birth. Infants infected with hepatitis B virus at birth are at very high risk to become chronically infected themselves. So immediate post-exposure prophylaxis of the infant with hepatitis B vaccine and hepatitis B immune globulin are critical. Post-exposure prophylaxis of an exposed newborn is somewhat more complicated if the infant is born prematurely and is low birth weight. Here is the first question about men. After today's visit, how many more doses will men need to complete her hepatitis B series? Men will need 2 more doses of hepatitis B vaccine after the dose she receives today. Men was born 5 weeks premature and had low birth weight. For the purposes of hepatitis B post-exposure management, low birth weight is defined as less than 2,000 grams. Low birth weight infants have a reduced response to the birth dose of hepatitis B vaccine. As a result, ACIP recommends that for low birth weight infants, the birth dose of hepatitis B vaccine should not be counted as part of the series. These infants should receive 3 additional doses of vaccine for a total of 4 doses. The additional 3 doses should be started when the infant reaches 1 month of chronological age. The dose men received today, at 5 weeks of age, was her second dose, so she will need 2 more doses to complete the series. Here is the second question about men. Your office stocks Pediarix, the DTaP-IPV hepatitis B combination vaccine. Can men receive Pediarix today? No, men cannot receive Pediarix today. Pediarix contains hepatitis B vaccine and usually can be administered as part of the hepatitis B series, including post-exposure prophylaxis of an infant. However, the minimum age for Pediarix is 6 weeks. Men is only 5 weeks old, so she is too young to receive Pediarix. The hepatitis B dose she receives today should be administered as single antigen vaccine. In fact, men is too young to receive any other vaccines except single antigen hepatitis B. The minimum age for all other pediatric vaccines is 6 weeks. Here's the third question about men. When should men return for her next dose of hepatitis B vaccine? Men should return for her next dose of hepatitis B vaccine in 4 weeks. Since men was a low birth weight infant, the birth dose she received in the hospital is not counted as part of the hepatitis B vaccine series. The dose of hepatitis B vaccine she receives today in your office is the first valid dose. The minimum interval between the first and second doses of the hepatitis B vaccine series is 4 weeks. When men returns in 4 weeks for her second valid dose of hepatitis B vaccine, she will be 9 weeks old. She will then be old enough to receive the first doses of all the other routine infant vaccines, DTaP, IPV, Hib, pneumococcal conjugate, and rotavirus. She will also be old enough to receive a combination vaccine such as Pediarix. Pediarix is not labeled for use in infants born to hepatitis B surface antigen positive women. However, in 2002, ACIP made an off-label recommendation that Pediarix could be used for infants born to chronically infected women. ACIP also made this off-label recommendation for Comvax, the hepatitis B Hib combination vaccine. Here are the next questions about men. Should men be tested for hepatitis B immunity? If so, when should the testing be done? Yes, of course, men needs to be tested for response to the hepatitis B vaccine and to confirm that she has not been infected with hepatitis B virus. The testing should be performed after she completes her hepatitis B vaccine series. The final dose of the hepatitis B vaccine series should be administered when the infant is at least 24 weeks of age and at least 8 weeks have elapsed since the previous dose. ACIP recommends testing the exposed infant for the presence of hepatitis B surface antibody and hepatitis B surface antigen at 9 to 18 months of age and 1 to 2 months after the last dose in the series. Testing should not be performed before 9 months of age to avoid detection of hepatitis B surface antibody from the hepatitis B immune globulin administered at birth. Testing an infant for antibody to hepatitis B core antigen is not recommended because passively acquired maternal anticore antibody might be detected in infants born to HBV-infected women for up to 2 years after birth.
We have many questions about hepatitis A and hepatitis B vaccines, and we'll address some of those now. Andrew, the first question's for you. The questioner asks, why must I wait 1 month to perform anti-HBs testing after vaccination?
Well, you have to wait 1 month to give the immune response time to develop. It takes about a month for the immune response to develop, and you need to wait that month so that you can make sure you don't have a false negative test. And I'll make the point here that you also have to make sure that you do this test after the last dose of vaccine. You have a narrow window. It's a 1 to 2 month window, because if you wait too long, you also run the risk of a false negative test occurring after that as well. So it's basically concerns about false negatives.
Thank you very much. Donna, the next question I'll offer you. A hospital employee has a record of hepatitis B vaccine series and tested positive on post-vaccination serology in the past, but now has a negative titer. Should you revaccinate this person?
We get that question a lot, and the answer is no. Once the person has had a positive serology, that you just need to have that documented, and they need to keep a copy of that. There's no reason to test them again. If you do test them again and you get a negative, it's very likely that what has happened is that their antibody has waned, but they still have that immune memory, so that if there's an exposure, then their body will mount that anamnestic response and their antibody titer will go up. So just be sure that you have that positive testing in their record and that they always keep a copy with them, because, you know, they might change jobs and need that again.
Thank you. The next question is also about hepatitis B. And Andrew, can you tell us about this one? If a provider is seeing a patient younger than 11 years who needs hepatitis B vaccine and only the adult single-dose vial of Recombavax is available, should you administer the full dose of this vaccine or draw out an age-appropriate dose?
You actually have to draw an age-appropriate dose of the vaccine. It's very important. Recombavax is one of those vaccines where it's actually licensed. You can use the adult formulation to vaccinate a pediatric patient or the pediatric formulation to vaccinate an adult patient. So FDA allows that. It's very important to conserve the volume, however, so you should give the 0.5 cc dose. You need to draw it off. Don't think about using the rest of it. You have to waste the rest of the vaccine, but you should draw off a pediatric dose and can administer it.
Thank you. Donna, let's move to hepatitis A. We've got a client reported to have received her second hepatitis A vaccine dose 5 months and 28 days after the first dose. Is this second dose valid or should it be repeated?
It's a valid dose. ACIP allows for a 4-day grace period, that is if your state accepts it and honors it, but they allow for a 4-day grace period between doses of the same vaccine. So for hepatitis A, the minimum interval or the recommended interval between the 2 doses is at least 6 months and 6 calendar months. And so the 5 months, 28 days does fall within that 4-day grace period, so it would be fine. You don't have to repeat the dose. But that's just between doses of the same vaccine that you can apply that 4-day grace period.
Thank you. Andrew, the next one's about hepatitis A vaccine as well. It says hepatitis A vaccine was administered inadvertently to a pregnant patient. Is this a cause for concern?
Well, hepatitis A vaccine is inactivated, so it shouldn't be a cause for undue concern. Hepatitis A vaccine, or pregnancy rather, is not a contraindication for hepatitis A vaccine, so we wouldn't expect any untoward events to follow a dose of this happening.
Great. I'm sure that's reassuring to the patient and to her provider. Well, that's all the time we have for our questions. Thank you very much for your attention. Thank you, Donna, and thank you, Andrew.
This brings us to the close of this session of Epidemiology and Prevention of Vaccine-Preventable Diseases. We would like to remind you of resources that you can use to get more information or to contact us. Here's the companion book for this program. The book is a useful resource for any office that administers vaccines to persons of any age. The Public Health Foundation is the sole source for a printed copy. In addition to the print version, the 12th edition is also available in an e-reader format. You can contact the Public Health Foundation through their toll-free number at 877-252-1200. You can also order materials online from their website at bookstore.phf.org. If your patients or their parents have immunization-related questions, you can refer them to the CDC Info Contact Center. You can reach the Contact Center toll-free at 800-CDC-INFO. The CDC Info Contact Center is staffed from 8 a.m. until 8 p.m. Eastern Time, Monday through Friday. If you or your staff have questions, you should direct them to the National Center for Immunization and Respiratory Diseases by email. Our email address is nipinfo@cdc.gov. Throughout this program, we've mentioned several immunization resources. You can find links to these and much more on the Program Resources webpage at www.cdc.gov/vaccines. Click on the Education and Training section, then the Immunization Courses link. Choose this program from the list to find all the materials we've discussed in this session. It's a good idea to have the most current immunization information quickly accessible in your office or clinic. An easy way to do this is to have the information available on your computer. We've compiled all the current ACIP statements, vaccine information statements, the course text, and much more on a DVD called Immunization Works. It provides a great way to have all your current immunization information together in one place. The DVD is distributed free of charge by the CDC. The Program Resources webpage has a link to order it. Continuing education credit is available for viewing this program. Details about the procedure for obtaining CE credit can be found in the Continuing Education chapter of the DVD or on the Program Resources webpage. Thank you for joining us for this session of Epidemiology and Prevention of Vaccine-Preventable Diseases. We hope you'll join us for other sessions in this series. Until then, goodbye.